Surgery, if you're neurogenic lower urinary tract dysfunction, is actually considered the last resort in these patients. And I feel that it often should be offered at a more earlier time point. Now, the prevalence of neurogenic, this is a tongue breaker, which I have to repeat all the time, lower urinary tract dysfunction is really unwell determined. So there's no exact figures, and it's wide variability in the reported numbers. You can guess by the incidence of neurological disorders. And spinal cord injury, for example, is in Switzerland 13.4 per million, Europe 12.1 per million overall. In Portugal, it would be 45. Japan 27 per million, and the US actually has relatively high rates with 54 per million, MS 5 per 100,000, and spina bifida 0.3 to 4.5 per thousand births. And it's thought that about 240,000 people with a spinal cord injury are living in the US. Now, the life expectancy for these patients is lower than in the general population. But as you can see here, a paraplegic who has his accident at the age of 20 will live for over 40 years, at the age of 40 at least for another 30 years. So their neurogenic lower urinary tract dysfunction has really time to grow and cause problems. And the causes of death after spinal cord injury are variable. The highest rates are cardiovascular diseases and respiratory diseases. But despite the improvement of management of neurogenic lower urinary tract dysfunction, it remains one large cause of morbidity and mortality, and it actually is the number one cause in 21 to 30-year-olds with an incomplete thoracic lesion. Spinal cord injuries are divided into three levels: suprapontine lesions, then spinal lesions, which are infrapontine to suprasacral, and then sacral or infrasacral lesions. And the ones that are at high risk are the spinal lesions. And these patients have an overactive bladder and an overactive sphincter, which finally causes dyssynergia and high pressure voiding and will endanger their upper urinary tract. The goals of treatment overall, number one, is to protect and preserve kidney function. Secondary goals in these patients are to regain or retain urinary continence and have a socially acceptable bladder function, preserve independence, improve quality life, and patient satisfaction. And we need to address two entities: bladder function, reduce pressure, and increase compliance and capacity, and sphincteric function, because mainly they will want to be continent. And surgery, as mentioned before, is the final resort for patients with persistent symptoms and complications not to be solved otherwise. The number of substitution cystoplasties or diversions in spinal cord injury patients performed in the US is about 112 per year, which is not a lot, and it is a complex and difficult surgery in these polymorbid patients. Prerequisites: the patient needs to bring some factors with her. It needs to be reliable, manual dexterity, willingness to undergo follow-up examinations, and the intellectual capacity to deal with the urinary diversion. The bladder has to be low pressure reservoir at the end, should be simple to manage and catheterize. As always, a simple surgical technique would be fortunate and few complications. And the typical patient that is referred for urinary diversion looks like this. She has been treated with medical treatment, intermittent self-catheterization, then Botox and self-catheterization, then an indwelling catheter with a flip flow, then an indwelling catheter on drainage, and now she's leaking alongside the catheter, has recurrent urinary tract infections, and is really unhappy. And if you do a urodynamic study on her, which is considered the prerequisite before surgery by everybody, you will see that she has a low compliance bladder and a detrusor leak point pressure the moment where she starts to leak urine, which is above 40 centimeters of water. And 40 centimeters of water is considered the dangerous threshold where you have to be careful what happens to the kidneys in the future. If you look at the video urodynamics, you see she has a small bladder with bilateral extensive reflux. Now, what do the guidelines tell us to do with this patient? Well, the EAU guidelines summarize the evidence. Bladder augmentation is an effective option to decrease detrusor pressure and increase bladder capacity when all less invasive treatment methods have failed. The recommendation: perform bladder augmentation in order to treat refractory neurogenic detrusor overactivity, and this actually is considered a strong recommendation. What does the AUA-SUFU say? Clinicians may offer augmentation, not a very strong recommendation, cystoplasty, to select neurogenic lower urinary tract dysfunction patients who are refractory to or intolerant of less invasive therapies for bladder overactivity or poor bladder compliance. And it's a conditional recommendation with not a high level of evidence. The NICE guidelines, which are the English guidelines, say augmentation cystoplasty should be considered, so that's a stronger recommendation again, for individuals with non-progressive neurological disorders, complications of impaired bladder storage, and after thorough urodynamic and clinical assessment and discussion with the patient and care team about complications, risk, and alternatives. And this is typical for the NICE guidelines. They always take a lot of interest in the patient's ideas. The ICI consultation on incontinence, video urodynamics must be repeated. For severe neurogenic overactivity, bladder surgery using intestinal segments may be considered. Stomach, ileum, colon, or ureter may be used. Ileum provided the best ease of use, lowest risk of complications, and highest efficacy, always as an end-stage treatment option. Now, classically, a clam cystoplasty is offered to these patients. What is important here is that you really need to open the bladder up completely. That can be a little bit scary. Come right down to the ureteral orifices. You can do it from side to side or front to back. That doesn't matter. But you need to open it up enough that the detrusor cannot have any coordinated contractions anymore. And after that, you take a piece of detubularized ileum. You can either just take the straight piece or a U-form shape, depending on how large a capacity you want to get afterwards. And these patients do well. The long-term scientific evidence shows that bladder augmentation is a highly successful procedure that stabilizes renal function, which is the most important, and prevents anatomical deterioration. However, lifelong follow-up is essential in this patient group, given the significant morbidity associated with this procedure. The urodynamic outcomes are really good. This is a systematic review. Bladder capacity goes from 107 to over 500 mLs. PDET max from 65 to 19, so we're really reducing the detrusor pressure, and detrusor overactivity disappears in the majority of patients. Continence is good with this 87% success rate, but the majority of these patients will have to perform intermittent catheterization. Quality of life is also superior. We have excellent good results in 83 to 92%. And here, a randomized study looking at Botox versus augmentation cystoplasty. And you can see that these patients actually had a superior quality of life, statistically significant after augmentation cystoplasty compared to Botox. And 88% were continent with a cystoplasty versus 42% with Botox injections. Now, our patient has a low compliance bladder with small capacity and a bilateral reflux with dilated upper tract. And you can imagine that this tiny bladder doing a clam cystoplasty is probably difficult. So the options is a urinary diversion. And the EAU guidelines, when no other therapy is successful, urinary diversion must be considered for the protection of the upper urinary tract and for the patient's quality of life. A continent diversion, again, should be the first choice. Bladder substitution with bowel after performing supratrigonal cystectomy to create a low-pressure reservoir is indicated in patients with a severely thickened fibrotic bladder wall. Intermittent catheterization may become necessary after this procedure. It generally does. AUA-SUFA say clinicians should offer urinary diversion to neurogenic lower urinary tract dysfunction patients in whom other options have failed or are inappropriate to improve long-term quality of life. And in a very recent study, again looking at sex effect on outcomes, bladder symptoms and satisfaction were a lot worse in women with spinal cord injury. Surgery was associated with improved satisfaction in individuals with paraplegia or tetraplegia. Surgery was more common in women because they are more bothered, but they had a substantial benefit. So earlier referral might make things easier. And surgery was associated with fewer bladder symptoms in both sexes and less incontinence in women. Now, reflux prevention is always a matter of discussion when we talk about urinary diversion, and there's not a lot of information assessing this. It's a matter of debate, and there's no mention in the guidelines. If you actually achieve a low-pressure reservoir, reflux will often disappear after surgery, and it may not be necessary to resolve the symptoms of UTI and preserve kidney function. In general, there are some indications that if you have a reflux grade 5 or after 10 milliliters of filling, it might be preferable to do an anti-reflux plastic. And these findings are in line with what we know from ortho and heterotopic bladder substitutes. The next issue is the outlet. So these patients will have to catheterize afterwards. Are they able to catheterize? One can imagine that our patient might have some problems, and we know that she already gave up on self-catheterization. And the other issue is continence. And going back and talking to her, she already had slight leakage when coughing or during transfer. So here, we really need to solve the problem with the catheterizable channel and possibly closure of the bladder neck. And this is only mentioned in the AUA guidelines. The EAU guidelines do not mention this. After a thorough discussion of risk, benefits, and alternatives, clinicians may offer bladder neck closure and concomitant bladder drainage methods to select patients with neurogenic lower urinary tract dysfunction and refractory stress incontinence. And the select patients, again, are the ones that are not able to catheterize and have an incompetent bladder outlet. What are the options? The most common options are a Yang-Monti procedure. Here, a tiny piece of ileum is isolated. You open it in an asymmetrical fashion, and this gives you a long piece in the lower part, a small vascular pedicle, and a short piece at the top. The long piece can be implanted into your bladder to give you continence, and the top is what comes up to this abdominal surface or the umbilicus. Mitrophanoff with appendix. The appendix can be trisected with a piece of cecum at the top, which gives you more length and a big channel at the outlet. You can use an intravesical tunnel or an extravesical approach. If it's an extravesical approach or a serous tunnel, you have to fenestrate the vascular pedicle, which can cause problems with vascularization. And you do see that appendiceal stomas are necrotic and close up. Outcome? In a systematic review with over 200 patients, 84% were able to catheterize, over 75% are continent. Tube stenosis is a problem in 4 to 32%, and there are a lot of reoperations for complications in approximately 40%. So the patients get a lot of benefit, but they have complications, and you really have to keep an eye on them. It's generally better to be able to implant your anti-reflux mechanism into the native bladder if possible. An appendix usually has better continent rates, but more stenosis. Bladder neck closure, which we will need to do in these patients to avoid leakage, can be done from a suprapubic, perineal, or transvaginal approach. Suprapubic approach has a lot of advantages. You have direct visualization of the bladder neck and prostate or urethra. You can mobilize the bladder up from the dorsal part of the vagina or from the rectum and close it in a tension-free manner, and also bring your suture lines better apart so you can separate them. And there it's easier to put tissue between your bladder, your urethral stump, and your bladder closure. The results, there's not a lot of data. The main problem is urethral leakage, which is why many people avoid bladder neck closure. 14% in 28 children, which is probably the largest series to date. And in pediatric series, there's urethral leakage in 0 to 24%. Prevention, again, as always in surgery, important to avoid overlapping suture lines, cover them with omentum, and mobilize the dorsal bladder so you really bring your sutures away from each other. And these patients really profit. So this is one of my patients. She was completely incontinent. She got a TVT. TVT eroded, was removed, urethra was closed. Now she had a urethrovaginal fistula, a repair, came back again. After that, she had a penny-sized defect in her urethral wall, was completely incontinent, was no way to fix that anyway because she was incontinent before and any other option. So we closed the bladder neck and gave her an appendix Mitrofanov. And she actually then was able to follow up on her sports career, intensify her training, was no longer bothered by incontinence. And last year, she won 2 marathons. And she also had 2 gold medals at the Paralympics. So these patients' quality of life is really improved in this situation. In summary, the guidelines give similar recommendations. There's a lot of variation in the grading of the recommendation. Surgery really improves urodynamic outcomes, protects renal function, and improves patients' quality of life. You need to pay attention on what the patients want, and the complication rate is high and lifelong follow-up is necessary. And this is a reason patients are often not referred for surgery until the bladder is so small that it becomes really difficult to deal with. But actually, an earlier referral would give these patients a better quality of life and protect their renal function. Thank you.